Hello, my name is Peter Morozov, and I'm professor of psychiatry at the Russian State Medical University in Moscow, and also I'm Secretary General of the World Psychiatric Association. It's a great honor for me to give a talk in front of a distinguished Pakistani audience, and I'm very grateful to Professor Afzal Javed, to Professor Nazar Said Khan, to Professor Khalid Mufti and Professor Imran Haider for inviting me to the International Psychiatric Conference in Lahore. The subject of my presentation is a review of international experience in the use of long-acting atypical antipsychotic. And my lecture is dedicated to the memory of Professor Paul Janssen, with whom I work in the World Health Organization some years ago. And this is really a brilliant person, 8 times nominated to the Nobel Prize, creator such drug as haloperidol, as risperidone, and some other forms of this drug. But in the same time, he was introduced one of the famous antidiarrheal drug, which has been used by the American astronauts when they went to the moon, or famous anesthetic, which permit the surgeon to surgery on open heart. But one of the main achievements of Professor Janssen is the creation of the concept of long-acting neuroleptics. And this is a long-term strategy which successfully developed even after his away. So for me, it was very important to analyze why this successful drug was not widely used. Using the experience in my own country, and tried to compare what is the situation in the other. For the first time, I would like to go to the WHO data, which mentioned that 10% of the world population suffer from mental disorders, depression over 30 million, bipolar disorders over 60 million, schizophrenia about 21 million people, dementia 47 million, schizophrenia 21 million people. It looks a little bit strange. And when I look to the other data, comparative prevalence indicator of the WHO received from WHO, we saw that the prevalence decreased in the last 20 years tremendously, and now it's only 0.26%. In the meantime, Professor Khaled Taminga, in her brilliant lecture in the WHO WPA webinar recently, mentioned that she's a specialist in biology of schizophrenia. She's mentioned that the prevalence of schizophrenia is 1%. It's quite stable figure. So let's leave it aside for a moment and go further. This is a contribution of non-communicable disease to disability. And you can see that neuropsychiatric disorders is 28%. It's approximately the same that cardiovascular disease, disability, and cancer together. And schizophrenia plays an important part of this disability. 2% of whole disability on non-communicable disease belong to schizophrenia. European College of Neuropsychopharmacology about 10 years ago undertook a very interesting study in which they evaluate the mental health across the Europe, and prevalence of total disease, brain disease and mental disease, it's 38.2%. It's quite high. At the same time, people suffering from mental disorder in Europe today estimated at 233 million, which is quite high. But What is more spectacular is the expenditure, direct and indirect, on mental health in Europe amounted to 80 billion euros, or 1 trillion US dollars. It was in 10,000 in 2010. But if we are looking to the recent data that for the world, cost of the illness, direct and indirect, $2.5 trillion by the year 2010 and $6 trillion in the year 2030. It's a very impressive figure because the question is this world societies could really overcome such difficulties. Third of the European population suffer from mental disorders every year, and mental brain disorder causes disability in 36.6% of the European population, which is significantly higher than in other continents. 2/3 of mental disorders remain untreated in any given year, with only 1 in 4 patients, 26% of the total number of patients receiving at least some minimal treatment assistance. For example, a short consultation course or a short conversation with general practitioner, which is really insufficient. And insufficient treatment noted in most common resort in children and young patients. But in the same time, WPA data shows that about 40% of the mentally ill start to be sick before the age 25. People with schizophrenia die on average 20 years earlier than those with somatic disease. This is also very tragic form. In the project of the Russian Society of Psychiatrists on epidemiological data of patients with the first psychiatric episode, we investigate about 14,000 patients from 12 regions of Russia, shows that introduction of modern antipsychotic therapy and rehabilitation of cohort of 1,000 patients with the first psychotic episode will allow per year reduce the risk of death up to the 20 to 44%, achieve prevention of disability and the rehospitalization, increase the share of employees students by 40% to reduce the cost of inpatient medical care, and to achieve a net economic effect in 3 years perspective. Well, before to compare what is going on in the other country, let's remind you about slow release antipsychotics, SAP, and the first, second, and the third generation. So SAP of the first generation, haldol decanoate, clopentixol, zuclopentixol, perfenazine decanoate, pipotiazine. SAP of the second generation is a slow release form of risperidone. Risperidone in the form of microsphere, and olanzapine, and slow release antipsychotic or SAP of the third generation is a paliperidone palmitate and aripiprazole in 2 forms. Purpose of our study was what is the frequency of slow antipsychotic of the third generation use around the world, and is there a correlation between improved long-term functional outcome in a given country and the frequency of SAP3G use in the particular countries. Inclusion criteria: 3 countries of conditional Western culture, USA, Spain, and Germany, and 2 countries of conditional Oriental culture, Japan and China. And predominantly slow release form of paliperidone or aripiprazole use, and preference for the study of use of third generation drug and the maintenance therapy of schizophrenia and schizoaffective disorders. Let's see the data from the United States that was published from the retrospective study. of use polyperidone palmitate slow release aripiprazole in adult patients with schizophrenia. And it is associated with the lower rates of hospitalization cost, the same data practically as in Russia, and the duration of hospitalization, and with better long-term functional outcome than the later initiation of treatment with the same drug after a year from the onset of the disease. So this was the analysis of the claims for reimbursement of treatment cost from database of Medicare and Medicare insurance company. So in Spain, the results of a retrospective observational study of only 89 patients with psychotic disorder from one of the hospitals in Spain who receive slow antipsychotic shows that the number of the drugs of the third generation is superior to any other drug of the previous generation in terms of anti-relapse activity, being the only drug among them that reduced not only the relative risk of hospitalization, but also the relative risk of relapses that did not lead to hospitalization. Compliance with the polyperidone palmitate was quite high, 73%. In 2019, the statistic on the use of slow antipsychotic in Spain is similar to that in all other European countries, but with a relatively high level of use of modern third generation slow release antipsychotic compared to a number of other European countries. However, the use of third generation antipsychotic is still insufficient. Germany. German authors studied the comparative efficacy, safety, cost effectiveness of different slow antipsychotic of different generation, as well as oral antipsychotic. The results show that 1 month utilization of slow antipsychotic of the third generation is superior to slow release risperidone, slow release olanzapine, and some other drugs, as well as oral antipsychotics in terms of anti-relapse efficacy and impact of the quality of life of patient. In another study, a retrospective analysis of the case history of 850 German adults with schizophrenia who began the treatment with the third generation drug between 2 years shows that all study included in this analysis, the total cost for their treatment and social rehabilitation, as well as the extent and the frequency of use of the resources of the medical system and the social security system, shows very positive results. It was shown that it was significant reduction of the total cost of treatment and social rehabilitation from average from 5,000, a little bit more, 5,000 euro, that more versus 11, practically 12,000 per year. Decrease in the frequency of hospitalization, 2.3 versus 2.6 hospitalization per year, and the number of days of hospitalization, 49.2 versus 73.4 days. This is quite important data show the advantage of the slow release antipsychotics of the third generation. Now we are going to the oriental part of our study, and the results of the open naturalistic Japanese study compare with the severity of somatic side effect, and they particularly analyze the heart rate variability. The study of 27 Japanese people diagnosed with schizophrenia the large part received some form of oral antipsychotic of the second generation or oral antipsychotic of the third generation. And another 29 patients received slow release third generation form. The results showed that the use of slow release slow release third generation form is associated with less severity of somatic disorder, in particularly with less variability of heart rate, especially in the low frequency range. So they look at this situation from the point of view of a somatic side effect. And it's also shown that the third generation slow release antipsychotic shown more that they are more advantageous. Despite of the very well-known advantage of using third generation drug in the maintenance therapy, in comparatively with others, the frequency of the use of this drug in outpatient with schizophrenia in Japan during this study period was only 3.5%. The prevalence rate of quantity remission in the survey population was only 41%. So we can conclude that the slow release antipsychotic of the third generation used in Japan less frequently than they should, which is really deteriorate the outcome and the prognosis of the disease. China, we have the 2-3 part of this investigation. Group of Taiwanese authors published the result of a retrospective study comparing the efficacy and safety of a different type of antipsychotic in schizophrenic patient. And the results showed that the mean follow-up time was about 40 months. It was possible to show that both in the first generation treatment group and the oral antipsychotic treatment group was a higher readmission rate, a lower treatment compliance, a shorter mean time to readmission, a trend to a longer hospital stay, and to a greater consumption of medical and social services, compared with the patient receiving more modern prolonged release drugs of the second and especially third generation. The authors from Hong Kong published results of pharmacoeconomic analysis of case history of more than 400 patients with schizophrenia from 3 largest public psychiatric clinics in Hong Kong. The analysis confirmed that yearly, less than 3 years after diagnosis, use of slow release antipsychotic of third generation is associated with the greater health and welfare saving than the use of the same drug in the later date. Let's see what is happening in Russia in comparison with the previous data. So the Xiplon, it's also polypyrimidone palmitate in Russia, in physical term increase from 0.07 to the total antipsychotic market in the 2017 to 0.09 in 2018 and to 0.12% in 2019. So it's really ridiculous. It's a very minimal increase. In comparison of this figure with those atypical from the US and the Western Europe, as well from Japan and Hong Kong, makes clear that the potential of expenditure in Russia is enormous, even with the compared with the great potential for further expansion of this type of drug in Western countries. Well, here you can see the comparison table of using of the drugs in packages. Xiplion is 1 month, polypyrimidone palmitate, and Trevicta is a 3 months using of polypyridone palmitate in 2019. And you can see that we have lowest rate comparatively to the other country. But in the same time, what was discovered that first psychiatric episode showed that that psychiatrists should behave at the same time as cardiologists. And schizophrenia had been called possibly the worst human disease. In US, myocardial infarction is the leading cause of death, and schizophrenia is the leading cause of disability. But while cardiologists use very aggressive therapy for the first heart attack to prevent the second, we psychiatrists do not usually use it for the first psychiatric episode to prevent the more malignant second psychotic episode. However, a large body of evidence indicate that psychiatrists should behave like cardiologists when schizophrenia develops. And people who have experience of a first episode, which usually permanently destroy the myocardium, the risk of developing the second one is high, and the most patient with the first episode have a high risk of a second psychotic episode with a more extensive damage of the gray and the white matter issue of the brain. Although most patients with the first episode respond well to antipsychotic therapy and return to their original social and professional life, the likelihood of disability is much higher after episode 2. And like physical death, mentally, cognitive, social, and occupation fading in chronic schizophrenia occurs over decade. This is the number of patients first recognized disability due mental disorders per 100,000. It's a data receiving from Russia. This is a mental disorders which increase in 3 years by 1.8%, and in 1% increase the patient with schizophrenia in 3 consecutive years. And this is this show table that the duration of relapse over the time in schizophrenia, course of schizophrenia increase. At the same time, with repeated relapses, the remission time was shorter. This is, you can see 3 consecutive episodes when the duration of the illness increased and remission time was shorter. In conclusion, I would like to say that as conceived from the literature data, despite the wide availability of prolonged forms of antipsychotic, as well as despite the fairly long-standing recommendation for the use of modern, slow antipsychotic, slow-release antipsychotic of the 3rd generation, at the early stage, the course of procedure psychotic disease that was previously accepted in the era of dominance of first and the 2nd generation of antipsychotic, the use of 3rd generation antipsychotic, even in the US and the countries of the Western and Central Europe, is still insufficient, according to compare with the real needs of patients for these drugs. Meanwhile, the literature data show a clear statistical correlation of both short-term indication, total relapse rate, hospitalization rate, and indicators of long-term functional outcome with the frequency of the use of 3rd generation antipsychotic slow release in the treatment for procedural psychotic disease in that or another country. The benefit of using slow release antipsychotic of the 3rd generation in the treatment of procedural antipsychotic disease, even in the US and EU country, are still known to minority of both among practicing doctors and among patients. In Russia, the situation of awareness of doctors and patients about benefit of this drug with the frequency and the use according to the indication and comparative with the real needs for these drugs is even sudden. So this is a very sad conclusion, but at the same time, I always think why it's happening? I think there are a number of reasons. First of all, it's high price of the antipsychotics of the third generation. Secondly, is the market of this drug is decreased because the official figure of schizophrenia is relatively low and comparatively to the real situation. And the third one, I think that probably Dr. Janssen was too premature. Go ahead in time. He was really genius, and probably the time of the using of long-acting, slow-release antipsychotic will come soon for the profit of our patient. Thank you very much for your attention, and goodbye.